Welcome to Care Transitions Today, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association. Today, we are joined by Dr. Sweta Singh along with special guest John Shreve with MCG Health. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare makes her insights invaluable to listeners eager to learn and grow in the medical field. John Shreve is President and CEO of MCG Health. Before we get started, a message from our sponsor. MCG Health is the trusted source for truth for evidence-based clinical guidelines and AI-powered decision support. We empower case management professionals to make accurate, patient-focused decisions so everyone gets the right care. And now, let's jump right into our episode.
Hi, John. Thanks for joining us today. I'll go ahead and get started and probably start with a question for you. AI, related to the AI field, AI is opening new possibilities in the case management workflow. How do you see it enhancing case manager capabilities and reshaping workflows, while keeping a human decision maker at the heart of the decision making?
Sure. So happy to be here. The case managers, are sort of the heart of the hospital in supporting the patients, but they also have this great big workflow of trying to understand the status of every patient and where they're at overall. And AI can do a great job of stopping that paging through the EMR to find all the details and summarizing it into the core points. And from our point of view, relative to what's in the MCG guidelines, so that gets matched up. And then they can take all of that information and still make the key decisions that they were working on before, but without all of the busy work to gather all the information to get there.
That sounds great. So if I'm understanding correctly, it can be a pretty useful tool in terms of summarizing and help our decision making of where the disposition is, so we can channel our energy accordingly. As we know, each step has a different pathways. Do you also see it being utilized as, hey, we already have this summary of good information that we can submit it to the payers for authorization, for a speedier authorization?
Yeah, I think it helps provide the information in a format that the payers will appreciate more, because from a payer point of view, the things that drive them nuts is the same thing, just getting this pile of information that's very hard to sort through and find out what's going on. So if it gets summarized to the key things, key vitals, key problems, etc., then it helps them do their job a lot more effectively as well, and probably get to better decisions overall that work well for both parties.
Absolutely. How can case management leadership build trust in AI technologies, balancing human oversight with efficiency to achieve the best of the both worlds?
I do think it's a little bit of practice makes perfect, but you can't just say, here's the AI, go at it. It's going to take some support to get there. But it's also, typical change management principles of how you change the workflow for a team. I'm not an expert in change management, but I know that there's a lot of work that needs to be done to get people comfortable with changing from the way they've always done it into a way that's going to be, in the end, it gets the case manager to a place where she can work at the top of her license rather than spend that busy work. So hopefully that they get to that point and understand it.
Absolutely. And like you rightly said, it's always change management can be a big challenging thing. I can see this as some of the seasoned and experienced case managers saying, I can tell where patient will end up as soon as they walk in. I don't need another tool or something and more clicks. And sometimes it's just the learning something new and new technological thing can be a challenge. While I can see some of the newer case managers might find this super helpful, easy to use now, and things that they learn over time with experience, they're able to get it right away.
Yeah.
But
And I'd say in a totally different area, just inside our own company, our software developers, what my CTO tells me is that sometimes the younger ones are the ones more ready to adopt the tools than people who've been working the other way for longer. And so it's um, uh, it can be a generational issue as well.
right, no, and it's just the initial curve of getting over the initial hump of acceptance and trust building. Like, hey, is if I use the tool but it's not giving me what I'm looking for, or it's not accurate, no one wants to put the more effort or time into learning that. They want things to be refined first, but AI is totally dependent on learning it itself. It's almost like training a new case manager. It takes time. And
That's right.
as it grows, it gets more accurate and more user friendly. I think the key definitely, like you said, it's along with the change management, it's the human oversight still remains the key, that they still would need to. There are some human factors, but it's just helping us get there with the technological tools and summarizing things rather than digging up things.
Yeah, and we're not in a place where we think, oh, just let the AI do the work. It's got the AI can support you, but they can't replace can't replace the decision making of the case managers.
Absolutely. I think that leads us to the next question in terms of how can leaders in case management foster enthusiasm and confidence among their teams. So AI is seen as an empowering tool rather than as a disruptive force.
Yeah, and that's very similar to what we've been talking about. But we had a at our client forum, which is our meeting of all our clients. We had leaders from Sharp Healthcare came and present, and they built the process for a centralized team that oversaw the implementation. They laid out timelines for adoption, training, acclimating and case management staff. They got early champions that help them promote it and then show them how it impacts their daily life, maybe most importantly. And when they did all that, Sharp went from more than 15 minutes to document a case down to about 3 minutes using the AI tools from MCG.
Absolutely. That sounds great. And if I'm understanding correctly and summarizing it, I might still miss things, but as a leader, in order to be able to bring that um, change to the team, the key factor is one, knowing and understanding the product, to when you're implementing it, showing its impact, piloting it, starting with the smaller group, and then advancing and sharing with the bigger group and showing, like you shared some great data, and that's, I think, would be a key power here. Hey, it will help reduce the time it takes from 15 minutes to 3 minutes. But as a provider, I can see that takes time too. I remember when I started a new tool in my clinical practice, at first I was like, whoa, it's taking me more time. Do I really want to do it? It's just when you use that and train that tool, it actually, in the long run, helps with efficiency or bringing down the time. Initial might be a little bit harder to push in. Um,
Yeah, that's right. And yeah, sometimes it starts by taking a little longer, but then with time it goes back the other way.
right. Because we have over time developed our processes. We have our own way of doing things. and changing that is not easy. So, how do you see case management professionals leveraging compliance needs for the new CMS interoperability and prior authorization final rule to strengthen peer provider collaboration and overall patient experience?
Yeah, so I think the CMS rule um, uh, will provide sort of a standardized process that people can rely upon that includes the transparency that they're looking for, um, and using the FHIR standards to pass information back and forth. But at the same time, I think the AI that's coming isn't necessarily um, I think that'll happen with or without the CMS rule. So I think the CMS rule is a good thing, and I think AI is a good thing, and I think it will, the CMS rule, with the information being passed back and forth in terms of, what are the standards for this particular authorization? Let me see the rules, and then at the same time, and here's the key things to submit. Um, and at the same time analyzing that information using AI on both ends. So it's which is not in the CMS rule, but it's an important part of the process that we'd expect going forward.
Absolutely. And I think transparency is definitely one key thing that will help with patient experience, because why is one person's procedures authorized but not for the other, and so on? Like, there is definitely talk going around in terms of two people requiring the same procedure and variability either by the pair, or is what are the factors. And if we have a more transparent, as you rightly said, AI is coming, it's the future. The sooner we adapt and use it to analyze and find the key factors that impact, the more transparent and correctly we can not only identify the patients, but also when submitting for authorization, make sure we give the key information so we don't have to go through the denials and delays, and get the right authorization upfront.
Yep, I think that's right.
In terms of trusted building the trusted partnership with so many AI solutions emerging, how can case management leaders identify and partner with vendors who combine technological innovation with deep clinical and operational expertise?
Yeah, I think our own journey has been interesting here because we've had at least 60 vendors or sometimes customers come to us and say, we want to use our AI on your clinical content. And what we've realized over time is if that happens, then our content will start being interpreted in 60 different ways. And then it loses its meaning. And so we're really focused on building out the tools, and we have a team of informaticists, physicians, editors, et cetera, who are building out this information that allow the appropriate interpretation of our guidelines. And by the way, why did the 60 companies come to us? It's because their customers said, yeah, your AI is great. You need to work with MCG. And so we've been looking at how we build out the guidelines. We call the underlying information that helps AI interpret it, our metadata, and building that out in a way that we get a consistent interpretation for either the payer or the provider of each situation relative to our guidelines. So, it's sort of, there are 60 companies coming to us because AI has gotten so much easier to do. That's almost become the commodity. While the deep clinical expertise that we've built up over probably about 30 years has become sort of the thing that guides the industry on both sides. And so you need that, and you need AI, and we're combining the two to create the solutions that we have.
That sounds great. And I totally agree. We need a more reliable interpretation than reducing the variability. In terms of when you're building your own AI and trying to not have almost like sounds like too many cooks in the kitchen, trying to utilize the same clinical data, what are the key factors or when you're building your AI, what are the key characteristics you're giving or guidelines you're giving to your team to make sure these are the things that's in place before we say, okay, our product is ready to be tested or shared with the others?
Yeah, we've actually built out a clinical review committee so that when we'll get cases that we use as examples to model out the AI on. Then we look for where our own doctors have disagreements on them, and pull that together and come to a conclusion as to, in effect, what's the MCG position on this. Sometimes it's on which guideline should you use, and sometimes it's on which interpretation of the guideline. Might be more in the first and the second, where we're which is leading us to build out other tools on that'll be coming in the future on the guideline selection process. But yeah, we've taken our sort of our intellectual types that are in our editorial process and brought them together to come up with the conclusions that we want to use consistently across all of our customers.
That sounds great, especially because I remind everyone, even our learners, when they are reviewing an article or information sheet, what was the source? Which research are they quoting? Because that's where a lot of time key lies. There can be different interpretation of the different research will have different end results. But what was the quality of the research that makes a huge difference? And sometimes we have great guidelines from organizations and best practices, but the strength of those guidelines can also vary. And uh, it's good to know that we are having a reliable source and vetting and almost stress testing our guidelines to make sure we are doing the right thing for our patient. And it's great to know that there is a quality check process too, especially because AI can pull a lot of information, but sometimes the sources it pulls from or the way it interprets, making sure the providers, there is a human touch to it and some restructuring and quality check to it. That's good to know.
Yeah, and I would say I was describing our quality checks on the use of AI. Prior to that, we have quality checks on the guidelines themselves, which go to a lot of, you were describing more of the factors that go into building the guidelines. And it's, we do view ourselves as sort of the one independent source of the guidelines, not influenced by payers, not influenced by professional societies, so that we can balance the evidence with the patient at the center of that balancing to make sure we're coming to the right conclusions. And that's the thing we've been doing for 30 years. And then with layers of review, and then and that's sort of the thing that's earned us our trust with our customers. And now we're making sure we maintain that trust as we go to the AI interpretation of it.
That's excellent. Um, One of the greatest potentials for AI lies in the improving experience for both case managers via workflows and patients' health outcomes. What principles should guide its integration to support simplified care management rather than adding to its complexity?
Yeah. So, first off, I'd say we have a number of principles in there actually, of the Hearst Health Organization, beyond MCG, although we have very, very similar principles there. But it's making sure that we're recognizing that what we're building is for the patient, that we test it for biases, that we watch for the watch for the hallucinations to prevent or to best we can eliminate those, and while also protecting the privacy of the data that's coming in. So we have those overall guidance, and we're working to make sure that it's that combination of trust and then the principles of building AI that gets us to the overall tools that we're building out. And clearly, we're making sure that what we're doing is providing value in terms of reduced overhead, as opposed to, it wouldn't be a very good tool if it made it harder.
Absolutely. So, a little bit trying to elaborate more on the patient perspective. So, it sounds wonderful that we are trying to avoid the biases and have strong principles behind the AI product that we are building to maintain the quality and overall value of the care. Um, how do you anticipate this to affect the patient experience? I'll give you a simple example. When we are winning the guidelines as well, the quality of the recommendations, we sometimes run into the patients who are like, well, there are some things that's outlined. I would like that, no matter what the strength of that guideline might be. So, how do you anticipate this to help us with the patient experience as well?
Yeah. So, we're always in a place of what does the evidence say is appropriate care in this case, and our guideline is trying to direct that. That doesn't always say, therefore, it's easy to have a hard conversation with a patient who wants to do it anyway. That's still a role that the local provider has. We do certainly, with our guidelines, publish the evidence about why we believe this to be the case, so that if they're looking for the backup of why that is, which again may or may not be helpful to the patient depending on what they want to hear. I think the transparency side will help the patient. But it doesn't get by the "I want it anyway"
Absolutely. I think as long as it gives us the strength to explain why we are doing what we are doing, that transparency and that it's non-biased approach, then having that ability to pull those references is a great way to help improve. Like, I totally agree. We won't be able to get by for those patients who wanted things that as particular way we may not be able to convince, but those who are like, hey, someone's telling me this, why are you telling me something different? As long as we can explain that why, I think it's much more acceptable and helps improve that patient experience, especially for our case manager partners who are going in. Even if, for example, when recommending subacute rehab or skilled nursing facilities, um, there can be various reasons a patient might need, and things can be not always able to be captured in just one mobility assessment or one particular need. So, having these complex tree or decision making ability and able to explain that why helps tremendously if the decision comes out not something that we were looking for, or if it is something that patient wants to go home, but the recommendation is subacute rehab, at least explaining the risks would help. Here are the
Yes.
reasons. This is what it is pulling, and if they can still make their own decision, but sharing the why definitely helps. Um, what's the MCG roadmap looking like as far as the development of the future AI solution?
Yeah. So the thing we've had for a long time we call indicia synapse. So that's has helped the case managers in the hospital setting read the EMR, and that used both structured data as well as, before LLMs, it used natural language processing to identify the text that's needed to come to a conclusion. Um, sort of, I'm jumping ahead in the roadmap, but on that product, we'll be moving that to the large language models so that it can that has a much stronger context setting of the information than just NLP does. And so that tool will be advancing soon. But in the meantime, we're looking forward to the end of the year where we'll be releasing CareWeb QI Synapse, which is the payer product. So that's reading the information that's coming in from the providers. Payers don't have access usually to the EMR, so it needs to read it in a, off of the attachments or whatever is being sent by the provider to do a similar interpretation of that. And that's been all based on LLMs, but we use the underlying knowledge we've gained in building the provider side to be able to interpret that. And at about the same time, we'll also be releasing some APIs that allow some of the partners to access our reasoning as well to get it into their overall workflow. So we're looking at that, the release on the payer side plus further development on the provider side soon. We also have a separate partnership with a firm called Avo, and they've been working more on discharge planning and using our guidelines to identify what are the key milestones that need to occur day by day, and here what we're building out is we're using AI to help write a discharge note, which is sort of the carrot approach to this patient is ready to be discharged based upon this information, rather than the stick approach of alert fatigue or whatever of trying to get it to discharge, but still based upon the strength. So a lot of the guidelines we've been talking about are more indications for admission or for a particular service, prior auth. This is also things that have been in our guidelines for a long time, which is our day-by-day progression with milestones and how to get people ready for discharge on a timely basis. So we see that coming up. I think there'll be a lot more coming after that, but those are sort of the short-term pieces. A lot of further development of each of those tools, because it's we're getting a lot of feedback of people wanting this and then wanting more things beyond that. So we'll be building that.
Absolutely. I can see how people can be wanting more and more. There is no end to it.
That's right.
As I was listening, and I can imagine how it can be pretty challenging for peers to go through these faxed medical records. It's much easier to review when you know the system and you have the full access and you can develop your pathways. But it's almost like when you have these outside hospital transfers with 200 pages or 400 pages of stacks of medical record that you have to review and make complete sense of it, get a good summary out of it. And if machine can do it, who does not want it? And
That's
same
right.
with the 30-day length of stay patients hospital course, we all dread that. So if there is a discharge summary prep that something is summarizing, will also not only help with discharge prep, but a care being summarized between the handoffs from case manager to the next case manager as to what has happened, so they can get a better understanding of what prep work has been already done and what the discharge disposition looked like, especially if it is helping with identifying the care progression. Because am I 2 days closer to discharge or am 1 week closer to discharge? So we can tailor our efforts accordingly. This will, I think, knowing that anticipated length of stay helps tremendously in putting our efforts in a timely fashion. So when patients medically ready, we are ready for our disposition too.
That's right. And you've already come up with some new things we need to do, so that's good.
Yeah.
The handoffs and so forth. Yes.
I will be happy to share the wish list. It's like you need to have a wish list in order to make things come true.
That's right.
Any other thoughts that you want to share about your overall experience in terms of when you started this AI project and your current state and how do you envision your future state?
Yeah, I think it's certainly what we've learned is that it has to be a strong clinical and data science team to build this out. Can't just be one or the other. And as we've done that, I think we start replicating the trust that we have in the guidelines in the AI. And it's been a little bit of a journey for us to get there as well, to learn those things, to figure out how we're doing those. And learned a lot by having these 60 companies come to us and say, we want to do this as well. So that's been very interesting to figure out how to satisfy our customers while we have these folks. So there's a lot of partnership opportunities that will come going forward.
Sounds great. This was very helpful. Thank you for sharing.
My pleasure. Thanks for having me on.
At MCG Health, we believe every patient deserves the right care at the right time. As part of the Hearst Health Network, MCG delivers evidence-based clinical guidelines and AI-powered technology that guides case management professionals towards better outcomes for their patients. Over 3,000 hospitals, a majority of health plans, and many state and federal government agencies rely on MCG's trusted, unbiased clinical guidance and AI to support accurate, efficient, and compassionate care decisions. With rigorous scientific processes at our core and innovation in our DNA, we help case management organizations improve the patient journey while reducing unnecessary administrative burdens. MCG Health, the source of truth for clinical decisions. Learn more at mcg.com.